Hi, my name's Daryl. So if you don't know my story, I was diagnosed with Guillain-Barre Syndrome back in September of 2019. Then, after a really bad relapse and a poor nerve study, I was re-diagnosed with CIDP about a year later. So since that diagnosis, about once a year, my neurologist orders another nerve study, basically just to see kind of the status and the progression or hopefully non-progression of my disease. And the nerve study really has two components. The first one is called an NCV, which is a nerve conduction velocity test, and the other one is called an EMG, which stands for electromyography. So if you are a new patient who has suspected Guillain-Barre syndrome or CIDP, it's very likely that your neurologist or your doctor will be ordering a nerve study, because a nerve study is a really important piece of the puzzle. So you have your physical examination and it might show signs of the disease, but they really need to do a nerve study basically to see what the status of the nerves are. Now, a lot of people get kind of worried when they're getting ready for a nerve study, and at least I've never really had any issues with it, so I really don't think it's anything to worry about. Basically, for the nerve conduction velocity test, they basically do like a little shock in your arms that basically go to like a muscle. And yeah, it's bothersome, but I wouldn't say it's really all that painful. In regards to the electromyography, this is where they insert like a little really thin needle into your muscle, and basically your neurologist will kind of listen for irregular activity. And so, yeah, it's really important that you have this done, and it's also really important, you know, occasionally to get this test redone just to make sure that your disease isn't getting any worse, and hopefully you've stabilized, and maybe it's even getting a little better. Now, I did mention that your doctor would likely order this test, and basically with the physical examination showing signs of Guillain-Barre or CIDP, and then a positive nerve study, typically that's enough for your doctor to actually diagnose you with either of these diseases. So my neurologist, he did my physical examination, and then I got the nerve study done, which it was a positive nerve study. It showed signs of the disease. One of the things that he did, as well as he ordered some blood tests, basically to rule out other conditions that might mimic the disease. And after those blood tests came back negative, then I was diagnosed with Guillain-Barre syndrome. So after you get the nerve study done, typically your doctor is going to give you the results. And the results will have, I'll show you mine right here, kind of a summary of, you know, kind of what your neurologist saw, you know, basically to make it easier for you to understand. But it will also have a table like this, which kind of shows the values that he got or she got when doing the nerve study. And typically any values that are irregular are usually highlighted or asterisked, basically to, you know, to kind of show you that particular number and, you know, kind of draw attention to it. Before I start analyzing my own results, I do want to preface this video by saying I am not a medical professional in any way. You know, this is just my trying to interpret my own results based on my own research and discussions with my doctor. You really need to talk to your own neurologist about your particular test and what those results mean. So what I'd like to do now is basically discuss the values that are recorded, and especially the ones that are significant for either a CIDP or Guillain-Barre diagnosis. And we're actually going to use the nerve study that I did back in September of 2019, you know, kind of as a real example of kind of what your doctor would be looking for. And yeah, it should be pretty good. Now, typically when your doctor does the nerve conductivity velocity test, they're going to be looking at the nerves in both your arms and your legs. Now, typically for the legs, he's going to look at the peroneal nerve as well as the tibial nerve. And then for your arms, typically they look at the median nerve as well as the ulnar nerve. And so it's really important that they test at least 2 nerves in each body part so that they can get a positive or a negative diagnosis. So as we're kind of looking at the table, what you're going to see is on the far left-hand side of the table, it's going to show you the body part that that they did the test on. Now we're actually going to look at the motor nerves first, and the first column that's significant is this column called onset. Now if you notice, you'll get the values recorded in onset, and you'll also get the normal onset that they would be expecting to see. And any value that doesn't fall within the typical onset is going to be asterisked. I guess I'm saying that right. So if you notice in mine, this was actually pretty bad. I have asterisks on all my values. The first 2 values actually aren't that out of whack, but then the last 2 values are pretty bad. Now, basically, your neurologist will be looking for values that are greater than the typical onset, and if it's more than 50% above that value, which the bottom 2 are, typically that could be the basis for a positive diagnosis for the disease. So in regards to what onset means, it's when they shock you, how long it takes for that shock to travel through the nerve and actually activate the muscle. So the next value or column that we're going to look at is called amperage. Now this in neurologist terms, once again, is called the compound muscle action potential. And basically what this means is it's how well, once they stimulate that nerve, how well the axon of that nerve can actually stimulate that muscle. And so once again, you can see the values for that particular amperage, the normal values. You'll see that just to the right of that column. And you can see for my study, it was actually abnormal. So I've got asterisks on 2 of the rows basically. Now, typically, this isn't significant for both CIDP and GBS because this typically shows axon loss. And for most CIDP and GBS patients who have basically myelin issues initially, this is really not going to show. Now, if you have had the disease for a while, you can actually get the myelin damaged as well as the axon. And so for patients that are a little more long-term, you're going to see some axon loss. Now, in my particular instance, when my neurologist ordered my blood test, he actually ordered an antibody study. And typically they do this so that they can use that antibody study to kind of figure out if you have a specific variant of GBS. And actually mine showed positive for the AMAN variant, which stands for acute motor axonal neuropathy. And so the difference with my disease was it went after the axons as opposed to the myelin. And so it was showing that to my neurologist as well. But for most CIDP and GBS patients, you're really not going to see typically any sort of amperage or CMAP loss. So the last column that we're going to look at on my motor nerves is the velocity. So that's on the very far right hand column. This stands for conduction velocity, which is basically how fast the current runs through the nerve. This is typically very significant for CIDP or GBS patients because when you lose myelin in your nerve, then that directly affects the conduction velocity. And so you will see on my particular test, I actually only had 1 asterisk there, but typically you would see more irregular values in that particular column. Now, what the neurologist would be looking for is any value that shows a slowing of 30% or more. And that typically also, if you have two nerves that are irregular in that way, then that also could be the basis for a positive diagnosis. All right, so the next table that we're going to look at is the sensory nerves. So we looked at the motor nerves, which is kind of responsible for moving the muscles. The sensory nerves are more kind of how you feel sensations or like heat or things like that. Typically, Guillain-Barre patients as well as CIDP patients, they have kind of a combination of those two things. There are motor specific versions of variants of CIDP as well as GBS. There are sensory only kind of variations. And so, yeah, it's kind of important that your neurologist understands which variant that you have. But my neurologist told me he was like, regardless of the variant that you have, the IVIG or the treatment, we'll treat all of them. And so, yeah, he just got me on the IVIG quickly, or as quickly as he could. So we're going to look at the sensory nerves now, and we're going to look at the first column, which is basically peak and normal peak. And that really has to do with something called distal latency. So once again, this is kind of like a delay of the reaction of the nerve. Looking at my particular study, I don't have actually any asterisks for my distal latency. Typically, this would be something that would show. Now, unlike the motor nerves, the sensory nerves is typically any sort of variation, and it usually isn't any sort of percentage, but it's any sort of variation on the sensory nerves. If you have more than two nerves that have irregularities, then that is also, once again, a basis for a positive diagnosis for CIDP or GBS. So the other columns to look at in regards to your sensory nerve would be, once again, the amperage or amplitude. And this is similar to the amplitude on the motor study. But what makes this a little bit different on the sensory nerve is you're not stimulating a muscle, right? And so it's basically how much your nerve can, how much amperage changes with the nerve. And this is actually called SNAP, or sensory nerve action potential. Now, you'll see on my study that I've got 3 of the 4 have asterisks on them, which is, once again, very irregular. And once again, what I said is if any 2 nerves on the sensory nerves shows a regular value, then they're going to pay a lot of attention to that. The other column that we want to look at is velocity, and that's, once again, conduction velocity. And this is also that myelin loss that we talked about. And so you would look for any values that have asterisks on that particular area as well. Okay, so the next table that we're going to look at is something called the F wave. When you stimulate a nerve and it goes to your spinal cord or your spinal root or your nerve root, and then it will come back, they're looking at recording when it comes back, or kind of like when it rebounds. And this is really significant. One of the values that neurologists really pay a lot of attention to. And so either a slowed F wave or a non-responsive F wave, in my particular case I had a non-responsive F wave, also could once again be a basis for a positive diagnosis. Now, they wouldn't look at just F wave, you have to have also some other irregular values, but it's something very significant. So now let's go ahead and look at the EMG study. And this is a little confusing for me. I don't quite truly understand the numbers behind the test. It's a really interesting test. I mean, they insert the needle and it hurts just a little bit, but as your doctor inserts the needle, he's basically going to listen. And you're likely going to hear kind of strange noises as he's listening, kind of like to the response of your muscles. And yeah, basically the EMG test on its own is not going to tell your doctor too much. I mean, it's going to say that there's some irregular activity in your muscles, which is unusual. But really, he's going to use the results of your EMG and he's going to correlate that to your nerve conductivity velocity test. And that's going to help him or her better diagnose your condition. Now, recently in 2021, kind of a group of neurologists came out with new guidelines in regards to diagnosing CIDP. And what they did is the previous guidelines were good, but really what they wanted to focus on these guidelines was looking at variants. And for the particular variants, what kind of electrodiagnostic criteria as well as other testing criteria for a CIDP diagnosis, what it should look like. And so CIDP is often misdiagnosed, and a lot of times it's the variants that cause the misdiagnosis, and so they really wanted to pay special attention to this. So it's really good reading. I think it helped me understand things quite a bit better, and so I'm going to create a link to it in the video's description. So yeah, go ahead and check it out, and I think it will help your understanding of CIDP. So I really hope you found this information helpful, and perhaps the next time you have a nerve study and you're sitting down with your neurologist discussing the results, maybe it'll help you have a little better understanding of what those numbers mean. I really hope everyone out there is doing well, and I hope to see you in my next video very soon.